So for the attendees, you can either use the Q&A function or the chat, as we've been doing during the earlier sessions.
No open questions.
So maybe to start off, Dr. Wright, if you could just tell us a little bit about your journey into neurosurgery and specifically what drew you to doing complex spine fellowship and specializing that area.
Yeah, so when I was in medical school, between our first year and second year, there was an opportunity to do a trauma surgery externship for the summer. And I did that just in general surgery trauma in Morgantown, West Virginia. And there was a very specific patient interaction that probably kind of led me to where I am. But it was a young guy who had had an ATV accident and was a high cervical spinal cord injury. And it was pretty interesting at the time to see because, I was working with the general surgeons who primarily we're kind of triaging and consulting other services to do certain management aspects. But the neurosurgery team, had the patient. They took the patient for stabilization, decompression of his cervical spine. He went to a neuro ICU where he was managed primarily by neurosurgeons. And I just thought that entire aspect was really pretty interesting. And I think that was kind of my first kind of experience with any kind of neurosurgery. It's not something that you get early on in medical school. And most institutions don't have a setup where you're really interacting with neurosurgeons or a neurosurgery service until you're sometimes a third year or fourth year. And so that was kind of what led me into the initial interest. And then from there, neurosurgery is relatively broad in terms of subspecialization. You have a lot of options, but I did a fellowship in neurocritical care, and I also did a fellowship in spine surgery. And so again, kind of my primary interest being traumatic brain and spine injuries. And most of my elective practice being in spine deformity and spine oncology. So, yeah.
Yeah, very cool. It's always interesting when folks can point out a specific patient interaction like that, because I think, it's for some people, it's a little bit more broad in what draws them into the field, but it's great to hear those kind of stories. So what is your typical practice look like, with having an interest in trauma, but also doing complex spine, maybe in terms of like being on call, taking trauma call versus spine call, et cetera?
Yeah, so our setup here, so I guess I would kind of split my practice really into kind of three pieces. I have my elective practice, which is 100% spine surgery, which mostly is focused on revision surgery, deformity surgery. We have kind of more urgent referrals that come in for spine oncology cases and those kinds of things, but my elective practice is predominantly degenerative spine surgery. So on a standard week when I'm not on call, I'll have 1 to 2 OR days, one to two clinic days, and usually an admin day. Not terrible. Call weeks can vary. Our call is stacked. So I take trauma, brain trauma call, and I take spine call. And those weeks can be all over the place. Very, very busy. And what I tend to do, and one of the things that's maybe still a little bit controversial in neurosurgery, is that people who do big cases on a regular basis often struggle with busy call. If you have someone who's booked on a Tuesday for a T4 to pelvis and you're operating all night Monday night, are you doing that person on Tuesday a service? Tough to say. And so what I tend to do is I tend to actually block off most of my elective practice on my call weeks and just focus on call. And so those weeks can vary anywhere between 5 and 20 cases on a busy week. And so that's pretty broad. And then about 40% of my practice is critical care. So I do, I'm the only neurosurgeon that works in our neuro ICU. And I do that about a week every six or 7 weeks. I do roughly 10 weeks a year, is what it amounts to. And those days are a little bit different, right? So it's shift work. So, you come in at a time, you leave it at a time. It's relatively predictable, but managing all kind of aspects of neurocritical care, less so trauma focused in that aspect and more so on management of subarachnoid hemorrhage and complex brain tumors and post-ops and stroke, intracranial hemorrhage, those kind of things.
Awesome. And I assume that's primarily non-operative, managing more like a critical care doctor.
Correct.
Interesting. And did you do a fellowship in neurocritical care?
I did, yeah. So one of the things that's interesting about a lot of programs is there are several fellowships that you can do enfolded in either PGY5 or PGY6 year. Some of them now are requiring that you do it as kind of this transition to practice. So after you've done your chief year, so what some programs are doing is instead of doing chief year your 7th year, they're moving that to your 6th year and calling you a chief as a 6, so that you can do a fellowship your 7th year, which is kind of more in line with that transition to practice model. But for me, so when I was in residency at Case Western, we had 2 full years of elective time. So our 5th year and 6th year were totally elective. And so my 5th year, I did an enfolded fellowship in neurocritical care. My wife, who is also a neurosurgeon, got an MPH at Hopkins during that time. So those are those kind of years where you have like totally protected elective time, where you have the ability to do enfolded clinical fellowships. Those are huge. And so that's what I did my 5th year. And 6th year, I did an enfolded primarily clinical spine surgery fellowship. And then I did chief year, and then 7th year, we both went to Cleveland Clinic for spine fellowships at Cleveland Clinic.
Yeah, that's really interesting, and an interesting educational model to see how that's evolving. So the audience here is primarily students who are either in the senior medical student years and might be moving into sub internships, or some earlier on who are just thinking about neurosurgery. For those who are preparing for their sub-Is, what kind of advice would you give, maybe thinking specifically about managing patients in the ICU, or for spine patients to help a sub-I prepare?
I think one, be on time, be early. If you're not early, you're late. Show the people that you have a good work ethic. One of the things that it's we all understand that you may not know all the content, but outside of knowing the content, you can work hard regardless of what you know. So I mean, that's kind of the first and foremost thing for sub-Is that people look at is, did they get along with the team? Did they integrate well? Did they have good communication? Were they well received? And then did they work hard? Were they on time? And I think if you can check a lot of those boxes, regardless of what you know or don't know, that goes a long way. And then after that, showing the initiative to know what you don't know, to figure out where your weaknesses are and improve upon those over, your 3-4 week block, whatever it may be. People notice, when you come in, you don't know something your first week, but then you know it and you're doing it, and able to kind of convey that by the end of the rotation. That's something that makes it into letters of recommendation.
Awesome. Yeah, great pieces of advice. And we had an earlier talk with Dr. Yang, specifically talking about some of the general sub-internship stuff, but it's nice to hear about the improvement aspect as well. So once again, I'm going to do a little bit of a call for questions if any of the attendees have anything. So again, please feel free to use the Q&A or the chat function here. Okay, so it looks like a question popped up here from Brittany. What is your biggest challenge in your work at the moment?
I think it's time management. I think, and maybe my experience is a little bit unique in that I'm a spine surgeon at OHSU, and my wife is also a spine surgeon at OHSU. And so we're just generally pretty busy. And we've got 2 young kids. So I think my biggest challenge is really time management and working within some of the constraints of a health system, right? So, I mean, there are certain things on your schedule that you just can't control and you can't move. And one of the things that you're almost lulled by in residency is the consistency of a schedule. So even though you may work long hours, you got to go to work at about the same time every day. You're going to the same place for the most part every day. You get home at roughly the same time with maybe some inconsistencies, but it's about the same schedule for 7 years. And when you're faculty, particularly if you're faculty where you cover multiple hospitals and kind of wear multiple hats, it's like my weeks when I cover ICU, those look entirely different, just in terms of my outside life, my family structure, all those things look completely different. For instance, now, so I worked overnight in the ICU, I'm covering the nights. So last night I worked from 5 p.m. to 7 a.m. And I'm up here doing a WebEx, in the daytime. So those kind of things tend to change. And then just managing an elective, like a busy elective practice. People always say that moving in to your first faculty position is a very tough thing, and it's stressful. You don't want to hurt people. You want to do a good job. You want to be well received. All those things. I think those are some of the challenges, and then figuring out how to be efficient. It's tough coming out and always second guessing yourself. Things that you do as a resident that you would never think twice about. You think twice about as a new faculty member. And so that's been a little bit of a learning curve, but very doable. I think you're muted.
Whoops. Yeah, thanks for answering that, and thank you, Brittany, for the question. And Brittany also says thanks for being here.
Yeah.
For a long night in the ICU. So you mentioned a little bit about, of course, you're in academic neurosurgery. Was there a point that you were split between potentially going into a private practice or a more private practice? And what does that decision look like for people? And as you answer that, I'm going to just switch over to a different device. So you're going to see a name pop up.
So I think whenever you're in residency, wherever you end up going in residency, some of the things that are the absolute most important are that you can prepare during your 7 years for whatever the outcome may be, right? And so you've got 7 years to kind of put your best foot forward, and whether that's going into private practice or academic medicine or whatever it may be, you going into residency, just as when you went into medical school, you will absolutely be a different person coming out of that than you are going in. All right. And so things change, priorities change. What you may envision your practice to be will change over your period of residency. And so I think just being prepared early on for whatever opportunities may come up, right? So if you don't know if you want to do academics, but you don't publish and you don't get grants and you don't seek out, opportunities in organized neurosurgery, then that door may close. And you may not have that option when you get to your 5th year, 6th year, 7th year, if you haven't kind of stayed ahead of that curve. And so I always knew that I wanted to do academics, but I was realistic in that I knew that there would be a potential, at least, that when my wife and I started looking for jobs, that it may be tough to find 2 academic jobs in the same city. And so we both were prepared for either of us to be either academic or private practice or both. And the way that we did that was just making sure that our CVs were as good as they possibly could be, such that doors weren't closed.
Awesome. Yeah. So you mentioned a little bit about, organized.
Oh, you cut out again.
Are you able to hear me now?
Yeah.
Okay, great. So you mentioned the importance of organized neurosurgery, and wanting to get into an academic career. And you were involved in the committee on innovation as a resident. So can you, tell us a little bit about what that work was like and how you first got involved in organized neurosurgery?
Yeah, so I mean, the CNS innovation committees were probably the least substantial committees that I ever were part of. So when I was a 4th or 5th year resident, I was selected as one of the Council of State Neurosurgical Societies, the CSNS Socioeconomic Fellows. And I was also elected to YNC, which is the Young Neurosurgeons Committee. So I kind of had a little bit of everything. So I was involved in CNS relatively early on through a number of avenues, and then with CSNS as a resident and now as a faculty member, and the same with Young Neurosurgeons Committee, YNC as a resident, which is now transitioned to a new kind of smaller committee focused on early neurosurgical careers. And I'm a part of that in the AANS. But I think being involved in organized neurosurgery, if anything, one, it keeps you busy, and it allows you to have connections or make connections that you don't even know that you might eventually need. And so, through some of those committees, I actually met my current chairman now, and some of that work. So I think it also, again, it just opens up a lot of doors that you may not know that you need to even necessarily open. And you may find along the way that you're not really interested in some of those things, but it's nice because you can tailor those experiences. All of the major parent organizations or organizations like CSNS have smaller subcommittees focused on particular things that you can kind of mold your niche to, right? And so for CSNS, there's a committee called the Neurotrauma and Emergency Neurosurgery, which is exactly my primary focus. And so I've been involved with them now for 4 or 5 years. And a lot of publications come out of that, good interpersonal interactions and connections in terms of being involved now with the joint section and neurotrauma and neurocritical care. So it's a way to really start building upon it, like the foundation of an academic career, for some of those things that are outside of your clinical and just purely scholarly activity. It's beneficial for your career in the long run.
Yeah, fantastic. And I think we, talk a lot about that involvement at the resident level. Are you aware of any opportunities for medical students to get involved formally, or does it tend to more be kind of informal if you know somebody who's involved already?
Yeah, so it's mostly geared toward residents. Actually, YNC, so the Young Neurosurgeons Committee, had medical student kind of liaison positions. But unfortunately, YNC, they just stopped YNC after the AANS meeting in Philadelphia earlier this spring. And so that has gone away. So as part of this new committee, this early neurosurgeons committee that is kind of taking the place of YNC, we haven't kicked that off yet. And so I can't really speak to the involvement with that, but most of our involvement has primarily been as residents or with residents. But I mean, there are, for instance, through Council of State Neurosurgical Societies, the CSNS meeting, there are proposals that go through every year to improve access to some of these organizations for medical students. And beyond just things like committee involvement, things like waiving the registration fees and things so that you all can be more involved and not have quite as many barriers to participation.
Wonderful. Thank you so much, Dr. Wright, for telling us about all of that. We have another chat question that came in. With 2 busy schedules, how do you manage work and family time?
It's tough. I mean, it's tough. I think you have to, it's an interesting thing about neurosurgery, and I work in a neuro ICU where I'm the only neurosurgeon. Everybody else is either a neurologist or an anesthesiologist. And a lot of people just don't fully understand that we don't ever clock in or clock out, right? And so, whether it's constantly getting epic inbox messages from patients or my chart messages or what it is, you find yourself working pretty much all the time in some capacity. For me, I'm a little bit fortunate in that we're both busy and we understand each other's schedules because we have almost the same schedule and we have the same kind of focus. So there's not really that lack of understanding of why I'm coming home late today or why this is happening, because those things happen to us all the time. And so, again, I think that one of the things that you really need to focus on, both as a medical student and a resident, is time management is absolutely of utmost importance, right? And if you're able to kind of master that or get at least good-ish at that as a medical student, that tends to put you in a better position when it comes time to application or comes time to submit your applications, because if you are able to efficiently manage your time, your CV is probably going to be better. All right. And when you get into residency and you're doing these things, your CV as you go through residency is probably going to be better. It's those people that really lack the ability to or lack the skills of time management that really just make it through. And so I think it's something that a lot of residency programs and a lot of medical schools really don't teach you, you have to spend some time and focus on learning those skills. And so, you know, when it comes time to family, there are times where work is off. You know, you just got to turn it off. And you got to tell yourself, no matter what's going on, I got to go home. I got to be home at this time. You know, I've got a 4-year-old who's in T-ball, which he seems to have T-ball games or practice like 6 days a week somehow, but I haven't missed one yet. And part of that is just the way that I do my schedule, right? So one of the things that a lot of medical students don't understand, and one of the questions that we get pretty frequently is, you know, what if I don't want to work so much? Or what if I don't want to, you know, whatever. And so in academics, at least, or in my situation, most surgeons are in a practice where they really just kind of expect you to be about average in terms of your productivity. Some surgeons are in practices that are really productivity based. And I'm fortunate that I'm not in that, as long as I hit my numbers, I can do whatever I want in terms of my schedule, in terms of, do I want to see 20 clinic patients today, or do I want to have a clinic where I go in at 10 a.m. and I'm done at 3 so that I can take my kid to school and pick my kid up when I'm done. And so you have a lot of flexibility with that. And you have it too if you go into private practice. It's just you may have to do that under the understanding that you're going to get paid a little less, right? But that's the trade-off.
I see. Thank you for that insight. That's something for sure that haven't been spoken of or heard of in the general population when it comes to being a neurosurgeon, and have flexibility in your time in a way and be able to plan and manage the schedules of the daily activities. But that's quite amazing.
Yeah. You certainly can mold it to kind of make it more of what you want in most places.
Wonderful. What would you say is your biggest obstacle so far, now that you're at this point of your career? Or when you have times where, I don't know if this happens, but like if you ever think of giving up or think of trying something else, how do you get through that and become who you are today?
I think I think neurosurgery in general is difficult. But as long as you have like a pretty firm understanding, and you have I would encourage everyone to seek out those experiences early, right? Because you don't know what you're going to enjoy or be able to endure if you don't do it first. And so really seek out some of those things. I never had any real second guess of anything after I did it. I mean, there are certainly hard days and long days and nights and next days. But as long as I think the one thing that is the most important when it comes time to try to pick a residency program or to pick a job, to be honest, is going into a place or a position where the people are the reason that you're there, right? And so with residency and my residency program at Case Western, our resident cohort was the most cohesive group of friends that I've ever had in my entire life in any setting. And so, a lot of places don't have that, but it's extremely, extremely important for your own like mental and like physical well-being, because what ends up happening is that you kind of lose sight of the fact that you're working really, really hard because you're all doing it together and it is a team-based approach. And so if you're in a place where those interpersonal interactions are a little more difficult, or you don't have really good friends that are in your program, those kind of things, it certainly is more difficult. And I just never had that in my training. We were always super, super close with everyone. And it helps tremendously because it just really prevents you from having those feelings of dread.
That's super wonderful to hear. So the residency program, the co-residents, the entire atmosphere of the residency hospital institution is going to play a huge
Would
part.
highly encourage people, when it comes time to like the next application cycle, don't focus on institution name, don't look at US News and World Report rankings, don't look at any of those things. Go to the places and look at the places that from a cultural standpoint fit the culture of where you think you would thrive, right? And if it's with a cohesive group of residents and those kind of things, I would highly, like when it comes time to make your rank lists, take those things into account. I mean, that was the number one thing that I took into account when I made my rank list, and it worked out very well.
I'm glad it did. And maybe going off of that, we hear the term fit a lot, right? Like sometimes you do a sub-I, sometimes it's only an interview. Sometimes now the interview is over Zoom. How do you, or what advice do you have for the students to find the best fit? What factors to look for? What tips do you have?
Yeah, so I mean, it depends on what you consider fit. And I think that, there are positives and negatives with that, right? So fit in general, and when we say things like, oh, are you going to be a good fit, or we want someone who's going to be a good fit, the only thing that you can potentially fall into is only having people around you who are like you, which is a little bit tough, right? Because there can be diversity concerns, there can be all kinds of other concerns, right? So you don't want to run into those things necessarily, but I do think from like a personality standpoint, it's really helpful to have people who are of a similar personality to you, just from a getting along and cohesive work kind of setup. But I think that the current group and the last year's group, the kind of COVID pandemic interviewees, really had the toughest time. And I don't know that I have any good advice, to be totally honest, as far as like how to mitigate that. I think that most places, the residents are very forthcoming, and they'll tell you what their experience is. I think that on interview day, whether you're in person or you're virtual, I think it's really, really tough because everybody's putting their best foot forward. Everybody looks like they're best friends. It can be a little bit misleading in that sense. The one thing that I would definitely encourage is second looks, if that's a thing that can ever come back. My rank list personally changed dramatically based off of my second looks and going and seeing what does it look like on a real normal day when there's not 50 people there, for an interview. And so those things I would encourage you to consider if there are options, not because it's good for the program and not because where they'll maybe rank you or think about ranking you, but it really allows you to see how those interactions occur on a day-to-day basis with the residents, how they interact with faculty, how faculty teach, how the ORs run, all those things that you just can't get a feel for by just going on interview day.
Got it. Sounds great. So because of COVID, I guess the second looks went away. Hopefully.
Yeah, I can't imagine that they're not eventually going to come back, but who knows?
Yes. Or maybe then turning the table and to look from your side. Now you're a professor, now you're no longer a resident. What kind of qualities or aspects do you look for in a medical student when you're thinking of, oh, will this person be a good match here?
Yeah.
Will this person be a good neurosurgeon?
Yeah, I think that's also something that the faculty are struggling with a bit at most programs, because again, we don't get to meet a lot of you in person. There are a lot of ways that a lot of programs are trying to mitigate that, whether it's by ranking systems, with specific point allocations for secondary degrees or number of publications or whatever it may be. So I mean, I think there are kind of those generic boxes that you need to pick or need to check. Are you published in neurosurgery? Have you shown an interest in neurosurgery, for a while? Have you done, do you have any diversity, equity, inclusion work? Do you have any, do you have dual degrees? Are you an MD, PhD? All of those things are important in terms of like the overall package. The biggest things really, I think, are going to be letters of recommendation from personal experiences. So, and personal interactions with other faculty members. Those now go so very far in terms of your ability to excel on your sub-I rotations. And people are very honest now. So one of the things that's changed over the last few years is that, we used to get these letters of recommendation that were just like pages and pages long. And now, and I don't know if it's as a result of COVID or what it is, that people are just so reliant on a good or bad letter of recommendation. Those are much shorter, much more succinct, and very clear as to where most sub-Is fall in pecking order. And so doing a good job on your sub-Is, working hard, those things that I talked about earlier, making yourself available all the time. Those things are really, really important because that's reflected in your letter of recommendations. And we also have these ranking systems now or not ranking systems, but the students are put into quartiles. So the people who write the letters of recommendation are also responsible for ranking the students in terms of their past experiences as being in the top 1%, the top 5%, the first quartile, the second quartile, the third quartile. So again, that goes a long, long way in terms of where the ultimate rank lists end up.
I see. So building those personal relationships starting from an early career stage would be very helpful.
Yeah, and it's tough because a lot of students don't have, you're really not involved with neurosurgery early on, and if you're not involved until you're a third year medical student, or even second year or third year medical student, you're not that you're late to the game necessarily, but it's hard. I think being broadly involved in things in terms of extracurricular things and volunteer work and all those things is really, really important regardless of what you go into. But work ethic is probably the like one of the number one things when it comes to evaluation of each applicant and relying on what someone else's experience was with that applicant.
Got it. That makes a lot of sense. Great. Okay, maybe if we can turn the tables a little bit more, as in, we were talking about neurosurgery in general. There are a lot of subspecialty fields in neurosurgery. I know you're more focused on the spine section of it. When did you decide, or what did you have to decide on which subspecialty you wanted to fall in? How did you come to that conclusion? And do most people now tend to specialize within subspecialties of neurosurgery, or are there still a lot of general neurosurgeons who practice all fields of surgery?
Yeah, I think most surgical specialties, not just neurosurgery, are now very much shifting towards subspecialization. And I think that's just been the shift for the last 10 or 15 years, to be honest. A lot of people, you still certainly have the ability to do general neurosurgery, and the bulk of private practice positions are really at their core general neurosurgery positions. The one thing for me, and it kind of goes back to being prepared from a CV standpoint to be a competitive applicant for an academic position or private practice position, is that you want to have the strongest application that you can possibly have. And what ends up happening is that as you're preparing for what may come down the line, you have to think about things like, as a spine surgeon, if I go into private practice, even if I want to focus on brain tumors, by the numbers, about 70% of my practice is going to be spine surgery, because that's just the way private practice works. There are not many private practice jobs where you're going to be 100% a brain tumor surgeon or 100% doing aneurysms all the time. About 70% of your practice is going to be spine. And so if that's going to be the bulk of what your practice is, regardless of what you want to do, you got to be good at that. And so that was kind of the approach that I took initially, was just a little extra preparation and time and making sure that I was just good at spine surgery. And then what ends up happening as a result of that is that if you have mentors and you have people that you're really drawn to and that you interact well with, you tend to go into that. And you get some inspiration and you find some, whatever positivity it may be. And then you just kind of start down this line. And so that's what it was for me. I think most people, the thing now is that it's program dependent in terms of when you start thinking about subspecialization. So for instance, at OHSU, we like you to start preparing for your research years or your elective time by the time you're about a PGY3. And when we chose to do fellowships, I had to make those decisions. So I think we signed our fellowship documents with Cleveland Clinic during maybe my PGY 5 year or 4 year, so 2 or 3 years in advance. So I think from a timeline standpoint, most people kind of make a decision in the middle of their residency as to what they want to subspecialize in. But the number of positions and the diversity of the positions are all over the place. You can always, if you want to do a job where you do nothing but open aneurysm surgery all day, every day, you can find that. You're not going to check all the boxes in terms of, it may not be, in Southern California on the water. It's not going to be in San Diego, but you can find that job somewhere. And so there's always going to be those kind of gives and takes. But it depends on, again, you having an understanding of what things are most important to you, and then just preparing kind of as you go. So long-winded, but you can do whatever you want to do. Subspecialization generally starts happening middle of your residency. And I think actually some of that may end up changing if we all move towards more of a transition to practice model, which would allow you to be kind of more of a general neurosurgeon throughout your training with kind of a focused year that last year, which I think is a positive thing. What ends up happening in a lot of programs is you may do an enfolded fellowship your 5th year or 6th year, or you may only do research. And then you do your chief year, and then you kind of chief year, you're doing a lot of stuff. You're not really focused on one thing at most places. And it's not that you necessarily lose those skills, but it's really tough to come in as a new faculty member and only do 1 or 2 things, because the way that you think about that and the way that your mindset is just, it's a different kind of framework than it is from being a chief resident who's managing everything. And so that is a little bit of an adjustment, just kind of getting back into a flow of things, both technically and from a scheduling standpoint.
Got it. So maybe following up on that, and since we're talking about adjustment, I know you said you did your residency at Case Western and now you're at OHSU. So what do you feel like there's a culture difference between, I guess, more of the coast neurosurgery programs, or is there any training differences?
So the structure of the programs are different in that when I was at Case, we had the 2 full elective years. The structure at OHSU is a little bit different in that they have we have kind of the base required elective time, but you move into this role during your PGY 6 year where you function as a trauma chief. So you do a lot of those trauma cases. And kind of manage the trauma service aspect during your PGY 6 year. And so the pros and cons to that for sure, right? So what it often does is it means that in other places where maybe if you were doing non-operative clinical fellowships for 2 years, moving into chief year is a little bit tough because you've been out of it for 2 years. And so that is a pro, and that people don't realize how much you lose in terms of your actual skills by not doing something for 2 years. And so that's a little bit different just in terms of the overall structure. From a cultural standpoint, I mean, everybody in Oregon is a little more laid back than people on the East Coast. And I think that's both an institutional thing. And I think it's just a West Coast thing. There certainly are differences. I've lived on the East Coast. I've lived in Ohio. I've been essentially everywhere now, and people are just more laid back here. It's an interesting dynamic, or it's a little bit of a different dynamic than what I'm used to, coming from a place like Cleveland Clinic where it's a big business, and it's just a different mindset here. So pros and cons to all of those differences, I guess.
Thank you so much for touching on that. Yeah, I've just always heard that there's people practice a little differently, treat their residents a little differently, even treat their patients a little differently when it comes to the coast to coast. So
yeah, I think there are these kind of traditional kind of very traditional beliefs in terms of kind of the more hardcore tough program kind of things, or like the East Coast versus West Coast mentality. I think that stuff is relatively similar. I actually think that it's more the administrative side of things that seems to be a little bit more, not lax, but just a little bit more relaxed. And then there are some things that you wouldn't even think about, like, I don't wear a suit to clinic. I don't need to wear a suit to clinic. No one expects me to show up in a with a tie on, just because that's not how the people here are. And so there are certainly going to be regional differences in those kind of things. But I don't know that one is necessarily better or worse than the other.
Exactly. Yeah. It's just going back to which one is a better fit, I guess.
Yeah.
Wonderful. Okay, if anyone has any more questions, please feel free to post them in the chat. And in the meantime, Dr. Wright, if you want to just have any last words of wisdom, advice to give to the students, we would love to hear it.
No, I think keep an open mind. Don't say that you know exactly what it is that you want to do. We always have a little bit of a question when someone comes in and maybe not all their research or not all their experiences in one thing, but they know for sure that what that one thing is that they want to do. So keep an open mind, work hard, particularly on your sub-Is and with those interactions like we talked about. And then start early, right? As early as you can, both in medical school and in residency, to make yourself the best applicant that you possibly can be, because you're not going to know where you're going to be or what you're going to want to do in 2, 3, 4, 5 years. Those would be the biggest things.
Thank you again. Really appreciate it.
Yeah.
Yeah. Michael, did you have anything else you wanted to add?
Oh, not right now, but thank you so much, Dr. Wright. That was a great talk.
Absolutely.
Wonderful. Thank you again. So we'll probably take a break until 2 p.m. and then we'll have Dr. Videra give us a talk about epilepsy. So if we can just hang tight for 13 minutes. Thank you all.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.